Thank you. It's a pleasure to be here and talk about the valvular heart disease guidelines. A good friend and colleague of mine, Blaise Carabello, told me a couple of years ago that guidelines are like sausage. Everybody eats it, but you don't want to know how it's made. And he told me that the American guidelines are actually mostly developed in the bar after the meeting. Well, I have to disagree there, because I think that the two of you did a great job in keeping it scientific and not having to lobby in the bar. So let's move on. And I am also starting with these two slides here to show you that we use different classes of recommendations. And that so you should keep that in mind. But most importantly, the levels of evidence that we are dealing with in the recommendations that we made in the guidelines. For prosthetic valve selection, they're mostly level of evidence C, and I think there's one level of evidence B. So most of the evidence out there is consensus of opinion of the experts and/or small studies, retrospective studies, and registries. We defined in the guidelines three key important determinants of prosthetic valve choice, and that's beside hemodynamic considerations, of course, is the weighing of the risk of anticoagulated bleeding and thromboembolism with mechanical prosthesis versus the risk of structural valve deterioration with a bioprosthesis. And thirdly, the consideration of patient goals, values, and life and healthcare preferences. And I think they are very prominent in these guidelines. There's a few minor remarks to make there about the second, and that's in particular the risk of anticoagulated bleeding and thromboembolism is determined mainly by the target INR, very important to realize that, the quality of anticoagulation control, concomitant use of aspirin, and of course the patient risk factors for bleeding. We should look at that total package. When it comes to SVD in bioprosthesis, we must take into account the rate of SVD, and we know that it's increased in younger patients and in those with hyperparathyroidism, and that it is higher in mitral position compared to aortic position. Finally, we should also take into account that nowadays the risk of a reoperation is only slightly higher than the risk of the initial operation. I think the most important slide here that summarizes this section of the guidelines is the fact that rather than setting arbitrary age limits, as we have done traditionally, we are now agreeing that prosthesis choice should be individualized, and it should be discussed in detail, not only between the cardiologist and the surgeon, but also with the patient as a partner. So let's move on to the table that deals with the choice in favor of a mechanical prosthesis. And in this table, I have underlined the changes that have taken place in comparison with the previous European guidelines. And as you can see, the first three recommendations remain more or less the same. Very important on top is, of course, the desire of the informed patient and if there are no contraindications for long-term anticoagulation. Secondly, those patients at risk of accelerated structural valve deterioration, a mechanical prosthesis should be recommended. Thirdly, patients who are already on anticoagulation because of another mechanical prosthesis, a mechanical prosthesis should be recommended. These are class 1 recommendations. What's new is that we now have dissected to the aortic and the mitral position some indications for age. A mechanical prosthesis should be considered in patients aged less than 60 for aortic position and those aged younger than 65 for a prosthesis in mitral position. And that's a 2A level C recommendation. A mechanical prosthesis should be considered in patients with a reasonable life expectancy for whom future redo valve surgery would be at high risk. These used to be in the previous guidelines two separate recommendations, but of course you need a reasonable life expectancy in order to have a future redo valve surgery anyway. Finally, and this is a change in a class indication, is that a mechanical prosthesis may be considered in patients already on long-term anticoagulation due to high risk of thromboembolism, for example, atrial fibrillation. This used to be a 2A recommendation, and it's now a 2B. Let's move on to the bioprosthesis recommendations. And again, here I've underlined the changes that took place in comparison with the previous guidelines. And again, the desire of the informed patient is a class 1 level C indication, recommendation. Then there's a slight change in wording here, I guess. A bioprosthesis is recommended when good quality anticoagulation is unlikely or contraindicated. And this is a change in wording. It was more general in the previous guidelines. Class 1 C, level C indication, recommendation. Then, and there's no change here, for mechanical valve thrombosis, despite good long-term anticoagulation control, a bioprosthesis should be considered. That seems reasonable. We then move on to the class 2A indications, and that a bioprosthesis should be considered in patients for whom future redo valve surgery would be at low risk. That's the same as it was in the last guidelines. A change, however, is for young women contemplating pregnancy. That used to be a class 2B recommendation, and now it is a class 2A recommendation. It should be considered. And finally, again, as we saw with the mechanical prosthesis, we have given some consideration to patient age, and for aortic position, ages over 65 years of age, then we should consider a bioprosthesis. In mitral position, this is older than 70 years of age, or those with a life expectancy lower than the presumed durability of the bioprosthesis.